Welcome to Diminishing Capacity, Nuts and Bolts of Assessing Expert Testimony on Cognitive Impairment. I am Jennifer McNeil-Lozano, co-chair of the BHBA's Trust and Estates Law section. Before we begin, I'd like to take a moment to thank our sponsors. The Trust and Estates section is sponsored by Bond Services of California, Liberty Mutual Surety, California Title Company, Pickford Escrow Company, and the Sanborn team. Now on to the program. I'm delighted to introduce our speakers, Dr. Sarah Mourra, Dr. David Trader, and the Honorable David Cowan. Dr. Mourra is a leading expert in geriatric forensic psychiatry and clinical psychiatry, who is double board certified by the American Board of Psychiatry and Neurology in adult psychiatry and geriatric psychiatry. She completed medical training at UC Irvine and obtained residency training at Yale, where she served as chief resident. She completed fellowship training in geriatric psychiatry at UCLA, where she was selected as a Bureau of Health Professions Fellow in geriatric psychiatry. She currently serves as an assistant professor in psychiatry at the UCLA David Geffen School of Medicine, where she teaches and supervises UCLA residents and fellows and teaches as faculty in their medico-legal elective. Clinically, Dr. Mourra is trained in psychotherapy as well as pharmacological treatments. Dr. Mourra also maintains a practice in geriatric forensic psychiatry, wherein she provides evaluations, record review, and expert testimony related to contractual and testamentary capacity, susceptibility to undue influence, probate conservatorships, elder abuse, and other areas related to older adults. Dr. David W. Trader is one of California's leading integrative general and geriatric psychiatrists. He received his undergraduate degree from Stanford University and his medical degree from Duke University. Dr. Trader completed his psychiatric residency and geriatric fellowship at the UCLA Neuropsychiatric Institute. He is board certified in general psychiatry and geriatric psychiatry. Dr. Trader has a private practice in integrative adult and geriatric psychiatry. He was formerly on the faculty at UCLA, medical director of geriatric psychiatry services at Cedars-Sinai Medical Center. Dr. Trader is an expert on legal mental capacity. He has lectured nationwide and testified in well over 100 trials involving mental capacity and undue influence. And the Honorable David J. Cowan is the one judge at the Los Angeles Superior Court assigned to conduct long cause probate trials. He has done so on and off for 8 years, rendering statements of decision in countless cases. Previously, he was supervising judge of the probate and mental health departments, as well as of the civil division. He has served on the Probate and Mental Health Advisory Committee to the Judicial Council of California and has taught wills and trusts at UCLA School of Law and Loyola Law School. Prior to going on the bench in 2005, Judge Cowan practiced business litigation for 17 years, starting at one of the largest U.S. law firms and then at his own office. He is a graduate of University of California College of Law, San Francisco, formerly known as Hastings, and Columbia University. Judge Cowan, now let's get started.
Thank you so much, Jennifer, and welcome to all of our attendees. And I want to also wish a warm welcome to our two doctors and thank them for coming in and joining us in the legal profession as opposed to the medical profession and sharing all of your great knowledge. In doing the probate trials, one of the most compelling for me and often most difficult parts of those are when both of you and or your colleagues appear and the court and the lawyers have to sort out the issues under the probate code that we're going to be talking about relating to whether or to what degree of cognitive impairment there may be primarily with a decedent or potentially or conservatee or prospective conservatee. Everybody has the PowerPoints, so we'll go through them as necessary. We also have some excellent handouts. Both doctors have provided those, so at your leisure, I do encourage you to review those because they are going to provide in more detail and as a takeaway what we're going to be covering here. We have a lot for the doctors to talk about. So we're going to have any questions we'll do if time allows at the end. But we do have a Q&A type function here. So if you want to ask any questions of any of us, we'll try to answer those if time allows during the program. This is also the first of two parts to this program, and so I encourage you to also come in on May 28th, at the same time, to hear about how the ideas we're going to be talking about today transform into opinions at trial and how this goes at trial. So today's program is going to be really fitted in. Will be 4 parts. The first part, we're going to talk about definitions and kind of give you an introduction to this general area. The second part, we'll talk about testing. The third part, we'll talk about the different medical providers. And the fourth part will show how these subjects apply when we look at the actual probate code sections 810 through 813, and primarily the 811, and how that breaks down the different types of possible impairment. So getting right into it here, to slide 6, relating to medical terminology. Let me first start with you, Dr. Trader, and if you can give us sort of an introductory to this general area of impairment, and in particular concerning what does it mean when we talk about major neurocognitive disorder, and how does that and dementia, and how those fit together, and so on.
Thank you, Judge Cowan. In planning this program, Judge Cowan, Dr. Mourra, and I sort of discussed how the nomenclature has changed, and some of the words can certainly be confusing when we talk about dementia or major neurocognitive disorder or mild cognitive impairment, and what do all those mean? And so what I'd like to do is share with you a little bit of the history of the terminology, just sort of briefly, and bring it up to what we call major neurocognitive disorder, and then Dr. Mourra will talk more about the specifics. But what we call, and I apologize, you may have it in your handout, we'll start with what's called DSM, the Diagnostic and Statistical Manual of Mental Disorders, and it's gone through several editions. I began in 1952 with the first one, and the present one, I think, was last released in 2022. But we had words historically. We call it senility, or a senile dementia, or organic brain syndrome, which some older physicians still use. And then you hear the word cognitive impairment, and then the word dementia. So what do all those terms mean? And what, at least in psychiatry, we've tried to do is shift that framework, because those terms, senility, organic brain syndrome, implied aging as a primary cause of this. And it didn't really talk about early cognitive decline, or and then there's certainly a social stigma, and that social stigma adjusted the terminology, particularly as DSM-5 came out, I believe somewhere around 2012, to this term major neurocognitive disorder, so that, for a number of reasons, so that we could increase diagnostic precision, certainly among mental health clinicians, particularly because many times other physicians might use other terms. But certainly when going through medical records, as you might, in certain cases, you're going to see various terms. So what do we mean by, at least let me define cognition, but cognition has to do with the general processing of information. It's not just memory, although quite often we think of memory as sort of the prime focus. but it involves language. It involves what we call visual spatial recognition, directions. It involves sort of what we call executive functioning, and that's a term we'll probably go over later on, but executive function has to do with planning, reasoning, organizing, sequencing. It's sort of in that category when we talk about mental function deficits under the Probate Code. It's the ability to plan, organize, reason, and carry out actions in one's own rational self-interest. So this term, and you may hear the term, so dementia is an what we call umbrella term. It's a general term that usually means a person has a significant deficit in cognition, usually memory, that interferes with social or occupational function. It's just a general definition, and it doesn't mean that as a general term that it inevitably goes downhill. Many dementia syndromes do, but some don't. But think of it, I often say, like cancer is a general term, and there are many types of cancers. So with dementia, there are many types, some somewhat reversible and some not. Then there's a term that's now come along. You might hear the terms mild cognitive impairment versus mild neurocognitive disorder. Mild cognitive impairment is generally thought to be a person with a modest cognitive decline that still maintains some functional independence. The cognitive deficits, particularly memory, might be recognizable to some extent. The person needs a little bit of support, but still remains somewhat independent. Whereas major neurocognitive disorder, this new term, which essentially is synonymous with the word dementia, generally means that there's a significant decline in cognitive decline in which there is a loss of independence or a loss of functional independence. So the person often requires help with finances and medications and many of the activities of daily living. So the features and we'll talk about there are many different medical processes that might fall under the umbrella of a major neurocognitive disorder that Dr. Mourra will discuss. But in general, think of, if you see, especially in medical records, you'll see dementia. You'll see Alzheimer's disease, let's say in particular, which is probably the most common type of dementia, certainly irreversible dementia. But that's just one type. And as I said, Dr. Mourra will discuss the specific.
I'm going to, in the interest of time, shift this over to Dr. Mourra and let her get now into some more of the specifics.
Sure, absolutely. Would it make sense, Judge Cowan, to talk about the types of dementia and significance? Yes. Or okay.
Please. Right.
So really, as Dr. Trader, so eloquently explained, I mean, dementia is really this umbrella term, and there's many different types of dementia. Why is this important? Why do you care? Basically, the reason is because the different types of dementia have a different sort of manifestation of symptoms, which then affects the things that sort of what people present with as they're, engaging in decision making, signing a contract, understanding what they're doing regarding an estate plan. So Alzheimer's disease dementia is, the most common. I think everybody's really fairly familiar with it. Usually memory is the most affected. Word finding, tends to be affected, what we call aphasia. As well as some elements of planning and organization, as we discussed in terms of executive function. So when somebody has that diagnosis, those tend to be the areas where they're struggling a little bit, and those do have relevance for certain types of decision making. We also have vascular dementia. This is a dementia that can involve a wide range of cognitive issues. It's very much related to vascular disease in the vessels that irrigate the brain. So it's basically damage occurring due to blockages within vessels of the brain. And there can be small strokes that are happening. So with these individuals, you may see they're doing great. They maybe have some mild issue, and then they take a real step down very quickly and abruptly, where they're doing a lot worse. And that's related to the burden of vascular disease and kind of mini strokes that are happening in the brain. So that's a very different kind of pattern that we see. Lewy body dementia is a different one. This is a very interesting, dementia where it's characterized by hallucinations, very vivid hallucinations. It's also characterized by a waxing and waning attention. So sometimes these patients look actually delirious, where they're kind of falling asleep and then all of a sudden they're really tuned in. So attentional issues can be present there depending on what kind of window you're catching that person in. They also have Parkinson's types of symptoms, very small handwriting, a soft voice, etc. And then there's frontotemporal dementia, which is another dementia that actually is very interesting. It doesn't have any issues with memory or executive function in the beginning. It's simply personality change. The person is rude, impulsive, inappropriate. They seem angry and easily angered, easily angry at others, or easily irritated with others. Behaviors are really dysregulated. They may have a lot of psychiatric kind of manic looking symptoms where they're making really impulsive and decisions that don't really make a lot of sense in terms of long-term planning. So these things can show up in the estate planning setting, and it's helpful to kind of get a sense that dementia doesn't just look all the same, that there are these different sort of types of dementia that can manifest in different ways.
How do you fit in delirium and psychosis, and how do those fit in or don't fit in with what you've just been describing, either of you?
Absolutely. So when we talk about psychosis and delirium, these are conditions that are separate from dementia, but they can be superimposed on top of the dementia, or even certain dementias, they develop a psychosis, right? So psychosis is basically, by definition, a belief in a belief that may be kind of paranoid or delusional, that is consistent despite evidence to the contrary. It can also encompass auditory hallucinations, visual hallucinations. And so, as you can imagine, people who have dementia that develop psychosis have another layer that may be playing into their decision making. So if I believe my daughter is poisoning me, and I'm disinheriting her as a result of that, that does have direct bearing. If I believe there are aliens living on the roof of my house, that's not going to affect my estate plan that much. Delirium is a second diagnosis that can be present along with dementia. In fact, having dementia makes you more prone to developing what we call a delirium. A delirium is an acute change in mental status that is related to a medical cause. So either anesthesia, over medication, a urinary tract infection is a very common one. Any sort of infection can cause a delirium. The way I would think about it is, when you have an injured brain, when you have dementia already, your brain is not working that well, and it is more prone to getting really confused as a result of the processes that happen with a medical insult. So patients with delirium look very, very confused. They may hallucinate. They don't know where they are. They may be agitated and require restraints in the hospital setting, etc. And the delirium will resolve, and the person often kind of returns to some sort of baseline that is not as bad as they look during the delirium. So this is why, if someone's in a delirium, it's really not a good idea to do any sort of estate planning or decision making, because that person is not really able to appreciate what they're doing.
All right, thank you. Let's move on to the next slide relating to testing. Starting, let's see, with you, Dr. Mourra, on this one. What about the mini mental, MoCA? Why don't you tell us, give us a little introduction to that?
Right, and I'll keep it brief. I don't want to like get too much into the weeds here, but so the mini mental state examination and the Montreal Cognitive Assessment are two tools that we use among other, I mean, there's certainly other tools that can be used, the slums being one of them, but in general, the mini mental state exam and the Montreal Cognitive Assessment are frequently seen in medical records or within, evaluations done by professionals such as myself and Dr. Trader. And these are screening tools for determining, is there a cognitive problem, right? What are the benefits or drawbacks to each? Really, there's one take-home point, among others, but the Montreal Cognitive Assessment assesses executive function. This is the ability to start, stop, sequence, and switch tasks. It's located in the frontal lobe of the brain. It is related to the ability to plan, weigh consequences of decision making, and understanding maybe more long-term outcomes of behavior. On the MoCA, it actually tests executive function. The mini mental exam does not test executive function. So that's where they have a pretty stark difference. The mini mental exam, both of them are out of 30. The cutoff for the mini mental is going to be 24. So 24 below indicates there is an issue, cognitive issue, again, with mild and moderate and severe ranges. And then the Montreal Cognitive Assessment, it's really the cutoff for normal is 26, so 25 or below indicates there's an issue. They all are looking at orientation, memory, delayed recall, attention and concentration, language function. So these are visuospatial ability. So those are covered by both of them. But in general, the Montreal Cognitive Assessment is a harder exam. It also tests executive function. When do we use mini mental? I usually use it when it's somebody that I know has some sort of cognitive problem, and I know that giving them a super hard exam is going to make them really frustrated and leave the room. So I will usually, in those types of settings, I might use the mini mental state examination with an extra piece on executive function added on.
Dr. Trader, what weight should we give to these different tests, and how does this might differ when you're looking at it after the fact versus as a clinician at the time?
Sure. And I can give you my thoughts, and Dr. Mourra, please chime in. But let me back up with these exams and just say for the audience, the mini mental state examination was developed in a hospital setting, and these tests were not developed for the medical legal session or the legal arena, let's say. As experts, we've come to use them in that way because it's a way of sort of helping as a tool to show where a person's level of functioning is. So that's what I'll say about that. And because they weren't necessarily developed for legal arena, I use them because if someone does really well, usually they're pretty good and can do most things, whether that's execute a testamentary document or a contractual agreement. And I think most of us in this area sort of agree that someone who scores below a 10, even on the easier mini mental state examination, is likely to have some impairment, maybe not capacity to marry, but that's a different story. So I place more weight on a person's understanding of their situation, which I think Dr. Mourra will talk about when we go over some of those mental function deficits. But particularly in a prospective examination, it's certainly easier. But even in a retrospective examination, which I think we're sort of talking more about now, if I can find some evidence of a person's functioning and understanding, I place less weight, but it does help, especially in medical records, to follow the progression if a clinician has done those tests well. Dr. Mourra?
I would totally agree with everything you said. Exactly. So, the assessment of whether somebody's able to do something, these tests are not a determination of whether somebody has capacity or not. They're simply a supplemental group of piece of information that we may use to get a full picture of where somebody's at.
I've had several cases where people have talked about UTIs and how that can be so eclipsing of people's thought, and it's kind of hard sitting there to think how that manifests, even though I'm hearing it, people talk about it. How do you um, assess, or how do you help a court deal with UTIs, for example, or other types of physical ailments that are non-dementia related?
Sure. It's nice if we can, especially when reviewing medical records or talking with people who may know the person in question, especially if we're talking about someone who's deceased, to get some kind of baseline level of functioning, or at least in the medical records, hopefully before there's a urinary tract infection, because that's usually an acute process, although it can last. But as Dr. Mourra said earlier, usually someone who is affected or has diminished cognition with a urinary tract infection probably has a compromised brain to begin with. And they may have that condition that she discussed called delirium or confusional state. It's very common with not just urinary tract infections, but many other infectious processes. So to look at it, Judge Cowan, it's nice to have as before and after, because usually that's something that clears, because often someone may test poorly or may be very confused, especially if they're in a hospital setting, and you'll see doctor's notes, other nurses' notes to say this person is trying to climb out of bed, or this person is picking at the air, or this person is just only knows their name and doesn't know where they are. But then later on, maybe after discharge, that person returns to baseline. So you have to get a picture of before and after.
Yeah, I mean, Judge Cowan, you may remember, I think we had a case where I had to go evaluate an individual's estate planning capacity. And when I asked what they had in their possession as assets, the person told me that all they had was burning luggage. And that was a clear, and that along with other signs of delirium that were there from a urinary tract infection led me to basically say, we're stopping this evaluation until this infection has cleared. I'll come back, once the antibiotics have kind of finished and he's clear.
So
So,
talking about medicine, um, uh, I know this is a huge topic in and of itself, but what should courts make of hearing that somebody is on one form of medication or another? And I think there's a lot of sort of the culture may think medication's not going to do that much good for somebody. So how do we factor in that? And I know that's a huge question, but if you can give us sort of some way into that a little bit.
Well, certainly that's case specific, but a lot of times what I hear, particularly from those in the law, is they make assumptions that someone who's on, let's say, an anti-anxiety medicine, the Valium family of medicines, or that person's on certain pain medications, there's a general assumption that those medications may impair that person, and certainly they can. I think one has to keep an open mind that sometimes anti-anxiety medicines might help that person. If that person's calmer, that person might be able to think better. Or if that person's in less pain, they might be able to function better. So it can go, medicines can go both ways. And I don't think there should be an automatic assumption that someone who's on certain medications can or cannot perform a certain act.
Anything you want to add to that, Dr. Mourra?
I mean, I certainly agree with what Dr. Trader is describing. It really can go both ways. I mean, one thing I would say, though, is that in an older adult with dementia who's in the hospital setting, who is naive to, let's say, a very high dose of opioid or benzodiazepine, it's usually pretty predictable that if they've never had that before and they're getting a massive dose, they are probably going to be out of it or confused. But really, the gold, the thing we're looking for in these cases is actual data about what the person looked like at the time that they signed. I mean, I will never forget a case. It was a person that was on a propofol they'd been given propofol, they'd been given high dose opioids. I was reading it and thinking, gosh, there was no way this person was alert and awake. And sure enough, the nurse had documented, niece came into room, patient was asleep, it passed out, and niece held her hand with a pen and signed the paperwork. So that is always going to speak more, give me a better sense of what actually the medicine did to the person. But in the absence of that, we're sort of trying to form a profile of this person. Were they naive to medicine or not? As Dr. Trader said, sometimes it can help, sometimes it can't.
So one phrase that I hear a lot, or term, is baseline or deviation from baseline. Can you, one or both of you, kind of give us what are we to learn from that? Dr. Mourra?
Sure. I mean, baseline is really, a term that we use to describe what somebody was like, as their regular level of functioning. How do we gather data about that? It's challenging if, let's say, the records you have are only from a UTI hospitalization where they were out of their mind and saying, crazy things and needed to be restrained because they were punching people and thought they were in a different place than they were. But overall, it's usually from primary care records or from, interviews with caregivers potentially, or from, sometimes even like video footage. You can get a sense of what was this person's baseline functioning? Were they able to kind of track a conversation? Were they able to, come up with, ideas of their own about what was being proposed? So getting a sense of the baseline function is really, really important, because unfortunately, sometimes when an individual is hospitalized, they don't look like their baseline. So we want to try to get notes from when they were not in hospital or when they were just kind of coming in for a regular doctor visit, for example, to get a sense of, is this somebody that could engage in this way, able to ask questions about what the doctor's proposing, able to understand what their med list was and talk about it? Or was this somebody where they needed someone with them who could come up with all that information because they are not able to kind of do that or engage with that? Dr. Trader, I don't know if you have any thoughts on this.
Sure. It's where I agree with you, but it's where someone is before any possible act or let's say change, because some people, let's say you have someone who's a physics professor who later on doesn't recognize that they're at home. You would assume that person at one time at their baseline was extremely high functioning, and then they change. And so it's really someone's basic level of functioning, with what we're talking about around, before the time of whatever act that's in question.
How far do you go back to determine a baseline for it to be meaningful?
It depends upon the situation, again, and let's say a baseline could be that a person starts out with, or they're already have a mild neurocognitive disorder or some type of cognitive impairment, and we get medical records and someone starts that way, and then let's say a year, and we go, let's say a year later. And that person by testing is shown and description is shown to be more impaired. So it's whatever you're given. I'm not sure it's how far do you go back. Yes, it's nice to know someone's basic educational status. That is important. That plays a role. And occupation, if there is one. So it's nice to know that. But it really has to do with what that person's like at the time.
So going to the next bullet point here, while the Probate Code wisely tells us to stay away from diagnoses and actually look at how people are operating, how they're doing, what about these terms mild, moderate, and severe? I mean, are there going to be situations, for example, where there is some level of severe impairment, where somebody is going to be able to still be able to think through what they're doing?
Dr. Mourra?
Happy to speak to that. I mean, it's always this, I think in training, they showed us this graph, and the two elements that play into whether somebody has capacity to make a decision is where are they at cognitively, and then how difficult is this decision, right? So the complexity of the decision, somebody that has like a $500 million estate and all these tax loopholes and all these things that they've done and all these, different sort of strategies relating to the estate, that's a different thing than somebody that's trying to figure out who to give their, vintage car to. Right? So it's you're looking at, the complexity of the decision. So usually, we will never say, oh, just because you have severe dementia doesn't mean you can make a decision, right? You shouldn't be allowed to make any decisions because your dementia is severe. No, it's always on a case-by-case basis, but the probability that somebody with a really severe dementia being able to make a highly, highly complex decision relating to like a trust and estate plan, multiple co-ownerships that are shifting, probably less. But again, it has to be assessed in the moment, at the moment, to determine, does this person understand, again, what the choice is, what the risks and benefits are, weighing those risks and benefits appropriately with their own best interest in mind? Are they able to manipulate information in a complex discussion? Those are the things that we are looking at. So yes, it is important to determine, are they in a mild, moderate, or severe phase of illness? However, it's not necessarily something that we use to say that they don't have capacity. I will be wondering what's going on when I get somebody that, let's say, is scoring in a very mild range, but then they have no idea what's going on with regard to the capacity evaluation I do. I'm going to be wondering what's happening. Is there a delirium? Like, is there something happening that I'm maybe not aware of that is explaining this discrepancy? So anyway, that's how I would maybe look at it. I don't know, Dr. Trader, if you have some.
Dr. Trader, I'm gonna move us on to the next question again in the interest of time, but tell us what we should be drawing from discussions of ADL and IADL, and how is that an important scale for us to, or something to us to think about?
Sure. So those letters, ADL, IADL. ADL stands, well, they're activities of daily living. That's ADL. IADL has to do with instrumental activities of daily living. So ADLs are basic functions that help us survive. Things like bathing, toileting, dressing, grooming, getting dressed, and picking out clothes. Those type of basic functions that we need to live. IDLs have to do with things like cooking and laundry and managing finances, being able to utilize transportations. That they're functions that we don't necessarily have to have, and many people have others do it to live. But where I find this is important because it goes into the definition of mild or major neurocognitive disorders or mild cognitive impairment dementia. In terms of mild cognitive impairment, again, or mild neurocognitive disorder, the person might need a little bit of help with some of these, especially instrumental activities of daily living, whereas generally a person with major neurocognitive disorder or dementia is fairly impaired and requires a lot of help. It also often fits into the concept of the issue of undue influence, because someone who needs a lot of assistance with activities of daily living, almost by definition, is more dependent on others for functioning. Now, again, that doesn't mean there is undue influence, but it makes a person more susceptible the more dependent they are.
Dr. Mourra, on the last bullet point here, alert and oriented by 3 or 4, person, place, time, and situation. Can you give us a little bit of insight into why three and sometimes why four, and what are we to take away from that?
Right. So, I mean, those of you who are familiar with kind of medical records, this is kind of something that's documented in medical records frequently, that someone was assessed and they were alert and oriented, ANO times 3, or sometimes you see times 4. This is basically a way of saying the person was aware of person, so they know who they are. So that's one. Two is place. So, who they are, where they are, and then time. So the date and the year. So when you see ANO times 3, that's basically a way of saying normal. This person is aware of kind of where they are, who they are, what's going on. They're not confused by this more kind of rough method. Now, in terms of alert and oriented times 4, certain specialists will write that as their normal. So alert and oriented times 4, meaning person, place, time, and situation. Why am I here? What is the reason that I'm in, this office, etc. But if you see alert and oriented times 3 or alert and oriented times 4, it's basically a way of saying the doctor saying this is normal. The person is not confused. That said, it's also the default setting in the computer program that people use to fill out their notes. They may not have checked, but it says alert and oriented times 3 is kind of the normal. So that's what I would say about that.
But if you choose to come in next time for part 2, we're going to definitely talk in more detail about the confusing world of reading medical records from hospitals. So that'll be just a tease for next time, as it were. We'll get into that more. Let's go on to the next page relating to providers. There we go. Thank you. So let's start with treating physicians versus forensics, like both of you are. Well, you do both, but I often only see you in the forensic world. So how should lawyers and judges deal with that distinction first in terms of ability to really provide useful information about a person?
Okay, I'm biased, and I'm sure Dr. Mourra is too, about those of us who do this, because I think especially you have to think in time with medical records, usually, especially hospital records, the clinician is not thinking, or even in office setting, the clinician is not necessarily thinking litigation. They're just documenting. And however, the more a person, a physician or clinician documents, and the more specific that clinician documents, the better it is for those of us who have to review those records. But quite often it depends upon, it may be difficult to tell other than in a deposition, the clinician's skill, because some clinicians will use Alzheimer's disease indiscriminately or not know what things mean, or quite often we get notes from primary care physicians saying, well, this person, I've been treating this person for 30 years and he or she certainly knows what they're doing as far as this person has the ability to change an estate plan without knowing the criteria. So my bias is that usually those people who are doing the medical records don't understand the law. And so that's when, someone who understands both arenas may be more helpful. So,
Mourra, make the case for your competitors, for the treating physicians, as opposed to forensics.
I've certainly done this before. I mean, I think every practitioner, there are certain things that are beneficial about their notes or helpful about their notes, right? I certainly think when someone has a really longitudinal relationship with somebody and they're very thorough, they get information in those visits that another person who's just meeting them for the first time may not get, right? So the therapeutic alliance, the trust with a primary care doctor certainly yields more information. Additionally, some primary care physicians are very attuned to family members and what they're noticing, and they have a relationship where they're getting some of that information. They're understanding, oh, this person used to come in looking great, dressed in a suit, but I'm noticing they've got stains on their clothing. Their hair is greasy. They're not looking like they're showering. They sort of know what they usually look like. That said, along the lines of what Dr. Trader's saying, part of the disease of dementia is a characteristic called anosognosia, which means I don't think there's anything wrong with me. And I'm not going to come to my primary care saying, I think there's something wrong. I can't remember things. I'm going to be saying, oh, my housekeeper stole this stuff from me and like moved this from this room to that room. And, they're not going to be recognizing there's a problem. A lot of the time, a lot of patients are really good at masking their dementia symptoms, especially with someone they've known for a long time. They focus the conversation on, how are your kids? How are you doing? Oh, I'm great. I'm having fun at the club, playing tennis. They're not delving. The primary care doctor sometimes doesn't delve as deep as, let's say, administering a cognitive test that can reveal this person is actually having some challenges. So there's definitely, pros and cons. I certainly think the therapeutic relationship that, the person has with a primary care doctor is important and shouldn't be disregarded. But that said, a psychiatrist or a neurologist or a neuropsychologist, they're going to be saying to the person, hey, I know you think you're fine, but let's give you a little test and see how you do.
Dr. Trader, when do I need to hear from a neurologist?
Ooh.
And what is a neurologist?
If you want to understand brain functioning, neurologists focus on we used to call it lesions in the brain. So if someone has a stroke and you want a neurologist to explain how a stroke impacts that person's functioning, or they may have Lou Gehrig's disease, amyotrophic lateral sclerosis, and functioning. I think there's often a bias, certainly, that someone who might have, for example, a stroke might have some impairments, and a neurologist can explain different brain areas of functioning or how that functioning might impact a person. So they're usually very specific.
Dr. Mourra, when do we need to see one of you as psychiatrist versus as somebody who's a psychologist?
It really depends on the situation. So with regard to sometimes there's people who are very confusing from a cognitive standpoint. You don't know, is their cognitive problem, is it related to untreated ADHD? Is it related to, medication side effect? Is it depression that's kind of presenting as dementia, which can happen? We call it pseudo-dementia. So when the cognitive screening such as MoCA or MMSE is not giving a lot of answers, sometimes we'll send somebody to a neuropsychologist to do a more comprehensive battery that also looks at personality and looks at, a lot of kind of more specific functions. Not everybody necessarily needs that. Obviously, as a geriatric psychiatrist, myself and Dr. Trader, we are specialists in issues of decision-making, issues of capacity. We're also specialists in behavioral issues, in dementia, in late life depression, manifestations of, post-stroke in terms of the mood and anxiety and behavior. So, we do have like certain levels of expertise that others may not necessarily have. We obviously are very familiar with the medical body and how medical issues within the body affect cognition and affect decision-making, which a neuropsychologist may not be as familiar with because they don't necessarily have that MD, that medical kind of piece.
Dr. Trader, I'm going to just again keep moving us along in capacity declarations. All of us, in probate see those, every day, and signed by a doctor. How did both of you? What are your insights into those what are your biases as far as reviewing those, and what weight should courts and lawyers place on those?
Well, I think they're helpful in one way of allowing the clinician who completes the capacity declaration to at least try to quantify a person's level of deficits. My concern, and may have talked about this, is that often those who are completing the capacity declarations don't necessarily know how to complete the capacity declarations. So I think they're important because they give some quantifiable evidence. You know, does some person have problems with orientation to whatever, mild, moderate, severe, that sort of thing. So it's important, but I think it a lot depends upon the skill of the person doing it, and if that person is has had some practice, or I think in doing those is someone used to doing those. So yeah, they're necessary. We have to have them, especially for conservatorships. They're a guide just like any other guide, but it depends upon the skill of the person completing it.
Dr. Mourra?
I would agree with what Dr. Trader is saying. I would say, though, the new capacity declaration form is way more detailed. So I love that. It gives me, again, if someone's filled it out accurately and properly, it gives a lot more data than we used to get on the old form. So, which I think is fantastic and helps in.
How much are
I
doctors
agree.
paid, or how much will insurance pay for the preparation of a capacity declaration?
Generally, well, it depends upon whether a doctor does that who accepts insurance as part of the examination. But technically, if it's if let's say a family member asks for this capacity declaration for legal purposes, technically speaking, insurance may not pay for that because they pay for something, especially Medicare, that's medically necessary. This form is not medically necessary.
Let's go to the next slide. And in the interest of, since we don't have much time, I just, the PowerPoints present you with 810, 11, 811, and 812. I'm not going to go use your time to go through those. You know what they are, but I did want to emphasize certain aspects of it and get our experts' input into them. In particular, one issue that comes up a lot is the issue under 811 of the correlation between a deficit and the act in question. And often, sometimes it, let's say a delusion might be fairly obvious, but less obvious might be how does that connect to somebody's drafting a will. How do you when you do your work, look at that issue of correlation?
Yeah, I'm happy to speak to
Please.
that. So, part of it is related to the interview, right? So I'm going to be, when I'm talking to somebody, I'm going to be asking them again, what is the decision you're making? What are the reasons for your decision? And then I'm also going to be asking, okay, so you've cited these reasons. What data is that based on? And then they'll give me that. And then I'll say, well, where did you get that data? Where did that come from? So, if they're telling me, well, I got the information that my son is a criminal who's embezzling money from reading his license plate, and the license plate numbers went in a certain way that indicated that he's untrustworthy, that's a lot of information about how they're coming to that decision. Again, and I'm going to be looking at, are there symptoms of psychosis? Are there symptoms of, sometimes a very severe depression can really impact decision making, and people don't care at all about what happens, and they kind of want to just be dead, and they want people to stop bothering them, and they do it to sort of just make that stop. So really, I think this is where the interview is super key to understand if there is a deficit there, like, is it impacting the decision, and how is it impacting the decision?
Thank you, Dr.
And
Frieda.
just for 1 minute or less, I would say there are a couple of aspects under 811 that I particularly look at, and that's under orientation to situation. Mentioned before, how well does the person understand their situation, and whether it's a retrospective review or a prospective examination. And the other has to do with the ability to plan, organize, and carry out actions in one's own rational self-interest, because and also abstract concepts, because if a person can understand more than just facts and put together and assess information, generally that person has the ability for a higher cognitive capacity, let's say, i.e. contracting.
The code looks also at timing. How long has things been going on? And one of the reasons we called this program diminishing capacity as opposed to diminished capacity is that people change, right? So how does that issue of time play into your analysis?
It's really important. I mean, if somebody is going to have, if someone has had an evaluation done as to whether they are able to make a particular decision, the closer in proximity to the actual decision being made, the more kind of valuable it is, right? Because with these patients or with these individuals, things happen and you can get like pretty dramatic changes in a fairly short period of time. So I would say I value it more, the closer in proximity it is. Certainly, I think once you're getting to, again, I don't know, Dr. Trader, what your thoughts are, but certainly when you're getting to the point where it's years or, kind of not outside of maybe the 6-month window without, again, with the caveat that there haven't been any intervening events, i.e. a stroke or some other catastrophic thing, I begin to, it becomes harder to say that the person looked exactly like that 6 months, 8 months before, 9 months before. But in general, dementia if it's dementia, it's a slow moving diagnosis if it is progressing. And, you're not going to get a change within necessarily a couple of months. But it's really on a case by case basis in terms of looking at what the deficits are.
And I would agree that timing is key, proximal to the act. But as Dr. Mourra said, let's say if at least we have 2 points in time for an assessment, and many times if that person hasn't had any, let's say a person, and Dr. Mourra, I feel that person has the ability to do whatever, and they're tested 6 months later and there's no change. If there's no major I usually think that if there's no major medical event that has occurred that would have caused them to decline in the interim, then usually that person, let's say 6 months prior, is probably okay. But proximal examination or some kind of assessment at the time is absolutely key.
So in our last minute or two, if we can move the slides forward to the breakdown under 811, you see here we've got 4 different categories: alertness and attention, information processing. If we go to the next slide, item 3, thought processes, and then 4, ability to modulate mood and affect. I'd actually like to, since we don't really have much time, is to go to that last category, 811, under item 4. If you go 3 more slides, keep going. So we have that in front of us. Keep it, and then the 4. So I'd like you both to talk about that, and because I think this is maybe one of the more difficult ones. And you look at there's 2 key phrases here. One, pervasive and persistent or recurrent state, and then inappropriate in degree to the individual circumstances. Are there things that you could share with us as far as that language, how you would, what you would look to see if somebody falls into one of those categories?
Okay, I'll just take a stab at it first. So starting with that last line, inappropriate to the degree of a person's circumstances. It goes back to what we were discussing as far as baseline. If you know the person's baseline and it's a calm person, all of a sudden they're just anxious or angry, it implies something that's going on. Or that person is happy-go-lucky and they get depressed. That because sometimes those depression may or may not affect someone's ability to execute a document, let's say. But some of these may go into, again, issues of undue influence. Dr. Mourra?
Yeah, I mean, I would definitely agree with that. So what's being referred to here is somebody that is having a clinically significant experience of these mood states where it's really impacting their life in a major way. I frequently see anxiety in older adults being a big player potentially in situations. When somebody has very severe anxiety, they are less likely to be thinking things through in terms of, is what I'm being told actually correct? Sometimes I've seen situations where the person was told, if you don't sign the house over to the neighbor, the government is going to take your house, because they're doing that to all older adults who need Medicare, just kind of being more likely to fall prey to this, because when you're highly anxious, you're not necessarily thinking things through. However, and I think I mentioned depression before. Impulsivity that can be found in certain kind of states can really play a role, where somebody is really euphoric and seeing things in a certain way and thinking that they have money that they don't have. All of these things can play a role, but again, it's on a case-by-case basis in terms of looking at the actual data of, did this condition actually influence, this decision?
Well, thank you both for your insights. I hope the audience has found this useful and give us a good introduction to obviously a complex subject that, but hopefully for those of you who may have little experience or no experience, we'll give you some starters to go by. Please come back on May 28. At the same time, we're going to go and discuss the preparation of opinions, how these opinions are given at trial, and issues that come up more in the courtroom than the sort of the more foundational issues we've been talking about today. So thank you, everyone. Unfortunately, we don't have any time for questions. In fact, we're over time, but we will look at the Q&A and the doctors and I will try to get back to you with those. So thank you again for listening in, and have a good afternoon. Thank you, doctors.
Thank you.